Where do you come from? Where do you come from? Geneva? Basel? Mm-hmm.
So good afternoon, ladies and gentlemen. Dr. Erne, Dr. Eckstein, thank you very much for the kind invitation. It's a great honor to speak in front of cardiologists. I'm a hepatologist and a gastroenterologist. I practice in St. Gallen. I have a lab at the University Hospital in Basel, and I think there's quite an overlap between liver and heart, and I think this is an extremely good idea to cover these topics this afternoon. So my task will be to talk about liver cirrhosis for cardiologists, etiology and diagnosis. In the next 15 minutes, we will talk about definitions and causes of liver cirrhosis. I'll have some slides for you on etiology and pathogenesis, diagnosis and staging in the third part. And finally, why should you as cardiologists care about cirrhosis? We will there focus on liver biopsy and anticoagulation, which is a frequent problem in our clinic, and cardiovascular complications in cirrhotics that you will encounter in your daily practice. I'd like to start off with this painting. I don't know if you know this doctor. For the hepatologist, he's very famous. This is the doctor that first described liver cirrhosis. He wrote that on autopsy, the liver was half the size of a normal liver, and warty and wrinkled, and there were many round or oval nodules. I'll give you a hint. You should know him more than myself. This is a tool that he invented. Anyone? Yeah, I'm fully aware cardiologists don't use stethoscopes anymore. You have more modern machines. So this is René Laennec, the inventor of the stethoscope and first describer of liver cirrhosis. So liver cirrhosis is defined as end stage of any chronic liver disease. It's characterized histologically, as I will show you in the next slides, by regenerative nodules surrounded by fibrosis. Clinically, we distinguish between two types, the compensated versus decompensated cirrhosis, which will be important also for your clinic. Just to give you some pictures here, on the left you see a normal explanted liver cut, and on the right side you have a cirrhotic liver with irregular surface nodules. Looking through the microscope, you can recognize that these nodules, which are composed of hepatocytes, are surrounded by this bluish collagen deposition, which is the hallmark of liver cirrhosis in biopsy. So there are many causes that lead to liver cirrhosis. Basically, every chronic liver disease can have cirrhosis as end stage. There are several groups. I mean, we don't have to go through each etiology. I have highlighted the three most important etiologies for Switzerland, which is alcoholic liver disease, non-alcoholic steatohepatitis, and hepatitis C. But there are many other causes from the autoimmune forms or metabolic diseases like hemochromatosis, Wilson's disease, and others that will lead to this end stage. However, 5 to 15% of patients will remain unclear. So although we do the complete screening, including biopsy, we will not find the etiology or the cause of cirrhosis, and we call these patients cryptogenic cirrhosis, which is in 5 to 15% the case. So the good news for the hepatologists this year is that finally, we have an extremely good cure for hepatitis C, which is one of the main causes of cirrhosis in Western countries. So from this year on, we will be able to treat patients without interferon, with a single tablet regimen that has cure rates of more than 90%. This is an extreme evolution in the treatment of hepatitis C. If you see at this slide from the 1990s, where we had cure rates below 10%, and which will now be 2014, 2015, over 90%. So this problem will be soon done. The bad news for the hepatologists is the global epidemic in obesity. So steatohepatitis due to metabolic syndrome is rapidly increasing, and with NASH cirrhosis also its complications. So all the different etiologies, they always have a final common pathway. And in chronic liver disease, you have activation of very special cells. So these are the liver-specific pericytes. So you as vascular specialists, you know that there's endothelium, and around the endothelium you have pericytes. And in the liver, these pericytes are called hepatic stellate cells. So these will be activated upon liver injury. There will be proliferation of these cells, and they start to deposit collagen and matrix proteins. And this is the beginning of the fibrotic process. So this slide summarizes 20 years of research in these cells. So the hepatic stellate cell here in the center, activated by different injuries. This cell will then change the phenotype and will show proliferation, contractility, deposition of collagen. And this is all driven by different angiogenic factors, such as PDGF, VEGF, which you are all familiar with, also with the downregulation of nitric oxide. These are all very important molecules in the process of fibrogenesis. Looking at the vasculature in the liver again, you see on the left, these are vascular casts. So if you inject a polymer in the vessels of animals, you can then digest the tissue and have a look at the vasculature by electron microscopy. And on the right side, you have a very impressive image of a cirrhotic liver. You see that these vessels are reorganized, remodeled. They have increased resistance. They are arterialized, and the endothelium is dedifferentiated. So a lot of the problems in the liver arise from the changes in the vasculature, and we will come to that later on. This is the natural history of cirrhosis. So after chronic liver disease, you will enter a stage of compensated cirrhosis. It's a question of time when complications will arise. Main complications in cirrhotics are bleeding from varices, ascites, hepatic encephalopathy, jaundice, and liver cancer. And once these complications occur, we then talk about decompensated cirrhosis, which predict that the survival time of these patients is dramatically reduced unless they undergo liver transplantation. So what is the prognosis in patients with liver cirrhosis? And I would like to show you a couple of easy tools that you can use to assess the severity of liver disease in your patients. So from a clinical standpoint, we divide, as mentioned, compensated versus decompensated cirrhosis. In the compensated stage, there's no ascites and no bleeding from varices. Maybe they have already varices, but they have never bled. However, in the decompensated stage, now going to the right, you have patients now with ascites, varices that sooner or later will also undergo bleeding. And if you look now at the 1-year mortality rate in these 4 categories of patients, you see that the compensated ones, they have a mortality rate in a 1-digit range, whereas those with stage 3 and 4, they have extreme high mortality, 20 and 57% respectively. Or just to give you like an overall number, once the patient starts to decompensate, its mean survival time will drop from 12 years to 2 years. So how can you assess now the severity of liver cirrhosis? You all know the child score. This has been replaced by a newer score, the so-called MEL score, Model of End-Stage Liver Disease, which is the best predictor for the 3 months mortality or survival rate in patients with cirrhosis. This is based on 3 easy parameters, so serum creatinine, bilirubin, INR. Put into this formula, which you don't have to know, they will reflect extremely well the 3-month survival probability in these patients. You see with increasing MEL scores, here on the y-axis you have decreasing survival. And in terms of points, so if you calculate 40 points from these patients, they have 0 survival probability in 3 months, whereas if you're below 10 points, your survival is pretty good with 96%. You can easily calculate this online. This is the website from the Swiss Association for the Study of the Liver. Or you have certainly many programs on your handheld devices. They usually also have the MEL score available. So diagnosis of cirrhosis. This is a histological diagnosis. However, in patients with chronic liver disease, based on their sonography of the liver and based on their clinical features, you can already suggest that these patients might have cirrhosis. And these clinical features can be ascites, splenomegaly, jaundice, asterixis, or spiders. However, these are not exclusive for cirrhosis, but have a high sensitivity. So most of the patients will undergo liver biopsy. This is the tool we use. It's a semi-automatic needle. We perform liver biopsy ultrasound guided. We have a trough length of 10 to 30 millimeters, which is a good piece to really do a good grading and staging of the liver sample. So this is an easy to perform and usually not complicated procedure. However, there's one major concern or complication, which is severe bleeding. The bleeding risk is low. I mean, 1 in 3,000 to 1 in 10,000 patients will have severe bleeding. It's less than 1 patient in 10,000 will die from this procedure. And since more and more patients are sent for liver biopsy, I think it's very important to talk about the optimum concerning coagulation in these patients, especially if it's patients that are referred from cardiologists that might have coronary heart disease. We have to make sure that their coagulation is okay. So just to give you a few hints here, thrombocytes, we'd like to have them more than 50,000, otherwise they need a transfusion. Coumadin is being stopped 5 days in advance. Clopidogrel aspirin, we stop it 1 week before liver biopsy. Other NSAIDs, it's okay to stop them a day before biopsy. They can be restarted, NSAIDs and thrombocyte aggregation inhibitors 2 to 3 days after biopsy, and Coumadin we usually start the day after biopsy. So life was easy until the NOACs arrived, so this made a lot of new diagrams available. So depending on the substance you're using and on the kidney function, you have to stop these NOACs 1 to 3 days in advance before liver biopsy and other high-risk procedures. I don't want to go into details. I'm more than happy to send you these slides. These are the internal guidelines that we have in our hospital. So you can restart these substances within 6 to 12 hours after liver biopsy. And the same, without going into details, is for heparins, be it enoxaparin or heparin. Be sure stop it 36 hours before in high-risk patients which are on BID dosing. There are some patients where you cannot stop clopidogrel or aspirin that have a covered stent, for instance, only a couple of months old, and that need for some reason to undergo liver biopsy. There is an alternative to percutaneous liver biopsy, which is transjugular liver biopsy. So we enter the circulation here, and then in the end we do the biopsy through a liver vein within the liver. So it will bleed, but it will bleed back into the liver vein. The advantage is that we can use this method in patients with impaired hemostasis. The disadvantage is that the samples are a little bit smaller than with the percutaneous method. And another advantage of this method is that we can assess and measure the portal pressure. So in cirrhotics, it's important to know how high is the portal pressure, and with this method, we can do biopsy and pressure measurement at the same time. Several methods have been developed to assess liver fibrosis and cirrhosis non-invasively. There's just one example. This is liver elastography, so with a special machine, which looks similar to an ultrasound. We can then induce vibrations to the liver, and the reflection of these vibrations will be measured, and the elasticity will be measured, and a stiff liver is a fibrosed liver, and there are certain cutoffs where you can say for almost certain that this patient has a cirrhosis. So coming now to the last part, the cardiovascular complications of liver cirrhosis. And this is important. I think you will certainly have more or less patients that have cirrhosis that will have these problems. So just systematically, there's the problem of cirrhotic cardiomyopathy. This will be dealt with by the next speaker, Dr. Mayer from Geneva. Portal hypertension is one problem. Hepatopulmonary syndrome, porto-pulmonary hypertension, and a general hyperdynamic circulation is typical for patients with liver cirrhosis. So in the hyperdynamic circulation, you will find increased heart rates in these patients. They have low arterial pressures. They have increased cardiac output and an activated RAS system. For the portal hypertension, we love to give a beta blocker in case of varices for secondary or primary prophylaxis of bleeding. The only beta blockers that work in patients with portal hypertension are non-selective beta blockers. So if you have a cirrhotic patient that needs, from a cardiology perspective, a beta blocker, it would be advisable to use a non-selective. We prefer carvedilol, which is the most potent for lowering portal pressure. And usually a dose of 6.25 milligrams BID is enough to have the best effect on portal hypertension. So last two slides, porto-pulmonary hypertension, you will have patients that come for invasive in your cardiology labs because they have pulmonary hypertension. So up to 8% of patients with liver cirrhosis have pulmonary hypertension due to cirrhosis. And this is an important problem because patients with this problem, if they have severe pulmonary artery hypertension, they cannot be transplanted due to post-operative problems. These patients usually are screened by contrast echocardiography and undergo right heart catheterization. And finally, hepatopulmonary syndrome, you will probably have patients that have very bad oxygenation, and this is due to hepatopulmonary syndrome, which is in the end an intrapulmonary problem where the microvasculature will dilate, the contact time of the blood will drop, and they will have insufficient oxygenation. So in summary, I showed you that cirrhosis is the end stage of different chronic liver diseases, that the hepatic stellate cell is the driving cell behind the pathogenesis. I showed you that this is a histological diagnosis. We talked about optimization of coagulation before liver biopsy. Please be aware that there's decompensated versus compensated cirrhosis, and once they decompensate, that the survival is clearly reduced. Use the MEL score to assess the severity of liver disease, and be aware of the cardiovascular complications that I mentioned. Thank you very much, and I think we will talk about the questions in the end.
Thank you very much.